This is Esther Ajailoa on February 9, 2026 at 10 a.m. CST in Houston, Texas, conducting an interview for the Global Oral History of PEPFAR projects. Good morning again. To begin, could you please start us off by introducing yourself? Tell us briefly about yourself, your family, where you were born, where did you go to school, just a little bit so that we can get to know you.
Thank you so much for having me. My name is Anthonia Aina. I was born in Nigeria, Oza village, in 1961 of July. So I'll be 65 this year. I schooled in Nigeria, in Delta, in my primary school. My secondary was in Edo State, and then I attended the School of Nursing in Lagos, Schools of Nursing Awolowo Rodikoyi, Lagos. I graduated 1987 and then got my first degree. I graduated as a nurse midwife, public health nurse, CHO, that's a community health officer. Then I went to the University of Ibadan to do my advanced diploma in health education. And then I went on to get my bachelor's degree in the University of Lagos, Akoka, Yaba, in health education. And then my postgraduate was I had master's in public health from the University of Lagos Teaching Hospital, College of Medicine Teaching Hospital in Lagos. I was in 2009. Yeah, my family lives here in the U.S. here in Houston, Texas. I'm a registered nurse, and I'm registered here. I'm licensed here to work as a nurse, and I work here as a nurse. I have 3 adult children, beautiful children, and 6 amazing grandchildren, and I give glory to God. Nice to be here.
Oh, thank you again. So, just getting to know more about your background. You worked in maternal health and infant health as a RN slash midwife slash public health nurse with Lagos State's Government Service Commission in Nigeria between 1991 and 99. Those were the years that Nigeria experienced a steady and significant increase in HIV/AIDS pandemic, transitioning from a low prevalence state to a generalized epidemic. How did you see the Lagos State's government's intervention on HIV/AIDS and the prevention of mother-to-child transmission during those years?
That's a long one. That's a very long one, but thank you for that question. When I graduated as a nurse, midwife, public health nurse, I worked with the Lagos State Government Service Commission in Lagos State as a nurse midwife, and I was, normally you work in the rural area. So I worked in the Ikorodu local government as a nurse midwife. I worked in the primary healthcare centers, manning the child welfare clinics for childbearing women. And I also, with my health education background, I was able to educate the women using audiovisuals and some other teaching aids on topics that will benefit the mother and the child, and also to give them enough knowledge to combat communicable diseases among the community, in the community, and also how to give proper nutrition to the children, to the babies, and also on immunization as well. So I was able to do that. I was also able to work in the community. I was able to work in school health, doing inspections and ensuring that the pupils and the teachers were healthy, they lived a healthy life, and they were able to imbibe healthy choices. I think that's about the question.
Yeah, in connection to HIV/AIDS.
As at that time,
specifically.
well, I joined the local government in 1991. And as at 1991, the issue of HIV/AIDS, or the talk about HIV/AIDS, was non-existent. At that time, people were naive. The virus was just, evolving. The prevalence as at that time was 5.8%. And we actually were working on communicable diseases and, trying to educate the community, trying to carry the community along. And we were not too bothered about HIV then, but it was in existence because in 1985, the first case was reported in Nigeria. And as at that time, we had little or no knowledge about HIV. So we just walked around communicable diseases. We walked around immunization to ensure that babies 0 to 5 had immunization. They were immunized against communicable, preventable diseases.
All right, thank you. Thank you. So still with the Lagos Government Service Commission,
Right.
You were still there from 1999 to 2005.
Right.
Now working as a principal health educator / HIV action manager.
Correct.
Right. So for those years, what changed around like HIV versus 91 to 99? So 99 to 2005.
Yeah. I was posted to the, thank you for the question. I was posted to the mainland local government. Lagos State had 20 local governments, and mainland local government was one of the local governments in the urban area. So I was posted from Ikorodu local government to mainland local government. In mainland local government, I was already principal health educator, the AIDS action manager, because as at that time in 1999, there was a circular. That was how it began. There was a circular from the Federal Ministry of Health for all local governments to inaugurate their local action committee on AIDS. Because at the national level, the National Action Committee on AIDS had already been established. So, and the HIV pandemic was gradually becoming noticeable in the community. So we were mandated, all the local governments were mandated to inaugurate. So in September of 2021, when that circular got to my table in my office, I took it and I ran with it. I ran with it in the sense that I had worked in the community and had observed, and I had seen people, what communicable diseases were doing to people. So the prevalence and was very challenging. So I took it and I ran. I got my team together. I worked with the medical officer of health, the then Dr. Oyeko, and then I worked with the chairman of the local government, Alaji Bolarinwa. I will just mention their names so you know that it's authentic and I'm being truthful. I worked with them and the other team, the councillors of the local government, the treasurer, the budget officers, the information officers. We all, sat down on a table and we talked about inaugurating, because I was particularly concerned about what was going on in the community. So we sat down and we decided that we were going to inaugurate our own committee. So we were I pioneered the first local action committee on AIDS in the country. I did that with the help of my team. So when we inaugurated that committee, we didn't know what was coming in for us in that local government area. And this actually catalyzed us to a lot of funding. So I'll go on to talk about how it evolved. I want to talk about Olukoye Ransom Kuti of blessed memory, Professor Olukoye Ransom Kuti of blessed memory. He was a protege of primary health care centers. He talked so much about, it started with talking about the government making primary healthcare centers available to people where they live and where they work, make it close as possible to where they live and where they work. And that also I experienced when I was doing community work in Ikorodu local government, when we were working in the communities where you have pregnant women driving, assessing healthcare, with distance so far away, they can't afford the cost of transportation, they can't afford even the cost of medical attention, right, or clinical cases. So they couldn't afford it. So Olukore Ransom Kuti was the first professor or a minister of health that made sure that Nigeria, we started having primary healthcare centers close to where people live and where they work, so that they can have access to care. So in the early 2000s, Olukore Ransom Kuti, there was a HIV walk in the stadium, National Stadium, where that was the first awareness program. So a couple of people attended, because as at that time, stigma was high, people were afraid, people were scared, there was misconception about the virus. People didn't even know what the virus was. What is this virus? What infection will affect people that there's no cure to it? So this was what the community was dealing with us at that time. So I think in 1978, was it? No, 1987, sorry. 1987, Dr. Olukore and Dr. Prof. Olukore Ransom Kuti dropped a bombshell that his brother, Fela Anikulapo Kuti, the legend musician, has passed, and that he passed from complications of HIV and AIDS. So that became the bombshell. That became the catalyst to which everybody stood up on their feet and we started working. That was how I started my program. That was how I was motivated, and everyone was motivated. I mobilized. So as a health educator, I had that skill, I had the knowledge, I had worked with communities in the past. I brought that experience to bear in mainland local government. So after we inaugurated our local action committee on AIDS, I want to talk about the action committee on AIDS. This local action committee on AIDS and HIV was a 30-member committee, because the circular that was sent to us spells out their modus operandi, how we are going to operate, what it entails. So it was a diverse group it was a multi-sectoral, multi-dimensional committee on HIV/AIDS, which included sectors of the community, opinion leaders, gatekeepers of the community, NGOs in the community, faith-based organizations, traditional bath attendants, youth leader groups, market leaders, just to mention a few. Everybody was represented in that committee. And I was the leader. I was privileged to be. And I'm happy that I was able to do what I was able to do. So now this committee was mandated to work in the community. So we started community mobilization. We started mobilizing the mainland community, sensitizing them with this new virus, this HIV virus that we didn't know anything about. Meanwhile, in the community, we were seeing people, observing people dying of the virus, dying from HIV, from AIDS. But we didn't know what it was. Nobody knew. We were just, trying to understand the virus. And the virus too was trying to understand us. Let me put it that way. We worked our hearts out when we started. We started with making sure that the community knew what we were doing. We went into the community to see the chief of the community, the Oba of the community. We call them Obas, they are community chiefs. So we did community mobilization with their support, because we can't enter the community without seeing the Oba and giving us his acceptance and his approval for us to go in there. So we were there, and then we also was able to go to the media, LTV8, picked me up and my team. Every World AIDS Day, which was April 7th, we were all out there for the World AIDS Day, to create awareness. So we made T-shirts, HIV Know the Show for face, there was no know your status then. HIV Know the Show for face. And then we went around the community with all our regalia, and we were dancing and talking to the community people. That was that. Then in 2001, after inauguration of the committee, FHI 36, no, it was FHI then, Family Health International, that was, they were supported by USAID. They visited the local government, the mainland local government, where I was the health educator and its manager. They came and they learned that we had already inaugurated our committee, so they were ready to work with us. So when they came into when they visited, they told us they were going to do like a survey to know the prevalence, because you have to start from somewhere. We didn't have data on HIV. We knew people were dying. We knew somebody would get, we didn't know what it was actually, because we know somebody is emaciated. Over 10% of his body weight is gone. You can visibly see the ribs. You can visibly see this person going to the toilet many times and having diarrhea and all that. All the signs and symptoms were there. We knew it, but we didn't know what it was. People were dying. So when they came, this team were a team of 4, I think, I remember. They comprised of Dr. Olufemi Oke, the country director of FHI Impact Project and Game Project, who is late, of blessed memory. Adetoro, Dr. Adetoro, and Ogundeyin, and I think one other person. They came, Dolapo Ogundeyin, actually, of FHI too. Thank you, guys. They did a great job when they came in. They told us, with my medical officer of health, we held excuse me, we held a DEX meeting. We had started with the DEX review of the situation in the community in mainland local government. I'm talking about the mainland now, because we had a structure on ground, which is the committee. So they felt that they could build on that. So they came in and we did a DEX review, and then we went on to do ethnographic study in the community, a survey, and then we came back and we got all the data together. Like I said, in Nigeria, when this virus began, the prevalence for HIV and AIDS was 5.8%. And as at then, there were no data. We had no data, but we relied on anecdotal data. So with the anecdotal data, we're able to put things together, and they decided to fund the mainland local government. So we became an interagency to FHI Impact Projects. So when the project began, that endorsed $45 million from the FHI USAID supported project. Okay, so we became an implementing agency to them. So that endorsed $45 million project, probably the mainland local government FHI project. So the project was to reach out to reach out to the community people, to get to know those who have the virus, and to see how we can, provide services to them, and also to see how we can mitigate the virus. So we started with that. I became the project manager. In addition to my portfolio originally as the health educator, principal health educator, the AIDS action manager, I became the project manager for this project now. So we have this new project that is just evolving. Now we had to get the LACA together. My team, we all got the LACA together. We told them about the project. The FHI team also told them about the project. We had meetings upon meetings upon meetings for them to understand. Then we also entered the community to see the community leaders. FHI and I and all my team, we were there. So we started this project of ensuring that each strata of the community had an idea of what we were doing. They were, number one was to create awareness on HIV and how to mitigate the spread. Number two was to identify persons living with the virus. Number three was to provide them with intervention. Another thing that was very important was to build capacity. Capacity of the people living in the community, capacity of the people providing the service. So FHI did a great job in mainland local government, and I'm very, very grateful to the work they did there for 3 years. The project was for 3 years. In those 3 years, our capacity were built. My capacity was built to be able to handle this project. It was a gigantic project. And the money that was given to us, or the fund that the local government earned from FHI, they were not liquid funds. You don't see the physical funds. They have mechanisms by which the funds get to you. It's not real money. It's not liquid cash. It's not dollars. You don't see it. You don't feel it. You don't touch it. It's a mechanism whereby everything we need was sent to us, but they were quantified. Financially, they were quantified. They had budgets and all that, and they will bring us whatever we need to accomplish whatever goals we have already. So we're working in partnership, and those days were really, really their days. They were dark days. They were days that discrimination was high, stigma was high. People living with HIV/AIDS will be evacuated from their homes. Their children will not attend school. It was bad. People didn't understand the virus. What they understood was that the virus had no cure. So everybody was being careful. But the issue which the issue with the community didn't understand was the mode of transmission. We all know that HIV is transmitted, basically 80% of HIV transmission, that's the virus, is through sexual intercourse, unprotected sexual intercourse, where one partner does not protect himself or herself, then they come down with the virus. And when they do come down with the virus, they do not know that they are infected. And another thing that was helping to spread the virus was multiple sexual partners, which both genders had, so it spread so fast and it spread so wide that people were coming down sick. So that was the end of the era for the 1990 to 90, I think, before the 2000s. So that was the early era of HIV in the mainland local government and in Nigeria generally. The next thing that happened was when I left the local government. We had already built capacity of the community people. We already established the LACA. The LACA were very active on ground, working with the different stratas and what we had in the community. We had structures in the community that were like soldiers. They were vicious. They will work with all the community strata in the community to make sure that the community was mopped up of people living with HIV. But then there was no treatment. Treatment was too expensive. As at that time, 1990, in the 90s, it was $15,000, 15,000 naira to access treatment. There was no treatment at all. People couldn't afford it. So stigma was high. People couldn't afford it. We saw them, And then we started with peer education training. We started doing peer education, peer-to-peer in the community. So we built their capacity to be able to reach out to their peers with the information, how to get HIV and how not to get HIV. Because as at that time, the myth for HIV was high. people didn't understand the virus because they didn't know. So we had a mandate to educate the community. So education was key. And not just educating, we're educating with audiovisuals, with teaching aids, with everything that we had. Condoms were available as at that time from non-governmental organizations. So they gave us a lot of condoms. They gave us a lot of condoms, and they gave us demonstrating abilities to be able to demonstrate how to use the condom correctly. Because a lot of people didn't know how to use the condom correctly. And so because they didn't know how to use the condom correctly and consistently when they have sexual intercourse, they came down with the virus. So we mandated. You will think it's something very simple. It's not as simple as that, because during sexual intercourse, some of these protection give way and the woman gets infected. You know, the biological makeup of the woman is wider than that of the man. So the woman gets infected more in the gender. So because we wanted to curb the spread, we did everything we could. We had models we had penile models and we had vaginal models. So we will demonstrate it to them, the correct and consistent use of the condom. And then when we give them the lectures or teachings, we expect demonstration. So we kind of recap with demonstration. So these peer educators were all over the community doing their work and, making sure that people understand how to use the condom. So condoms were available, but there were no treatment, right, at that time. So we had a lot of work to do. But during that period, just one more, because my capacity was built, I was able to put up a lot of abstracts writing about what I was doing in the local government for other countries to learn. To learn about what I was doing in my local government. So with the help of FHI, Family Health International Impact Project, I was able to write abstracts about how the local government local action committee was formed. The first local government action committee on AIDS was formed. And then the first VCT center, because then it was voluntary counseling and testing. It was voluntary. Everything was voluntary. Nobody was coerced to do it. You weren't coerced to do it. It's voluntary. We tell you, make your informed decision and come and test. There were no testing centers. So FHI, I still give kudos to FHI through the USAID funded project. The first VCT center in Odulami Street, the Salvation Army, was established, was inaugurated with the help of my LACA, of our LACA, of the mainland local government, Lagos State LACA, the first LACA in Nigeria. We were able to support the Salvation Army in Odulami Street in Lagos to inaugurate the first VCT center in Nigeria, the first voluntary counseling and testing center in Nigeria. And it was funded by the FHI Impact Project. And I was able to, provide services to them. Provide support to them with my LACA, because the LACA was for the Lagos State, though it was in mainland, but also because there was no other LACA that was inaugurated anyway. So yeah, that was it.
Oh, thank you so much. That's really great background information around that time.
Thank you.
And as someone who also grew up in the mainland development, I can really relate with everything that you're saying. And then I really appreciate you sharing your impact on LACA, which is also like part of NACAR, the national one, and all the things we were able to achieve with the FHI Impact Project through the help of USAID and gains, and that was really powerful. And thank you also for mentioning the impact of Professor Lukoya and Kuti, and that, when Fela Kuti died in 1997, it was
right.
like, okay, it was from HIV, and then that was also one of the ways that what came out and a lot of things that have been heard about HIV/AIDS.
Right.
And I also felt the impact of LACA when I was in secondary school.
Oh, really?
Would come and would do like small drama and all of that.
Thank you.
That was really great.
Thank you.
Yeah, so I could relate.
I appreciate that.
For sharing all of that. Thank you. Now let's come to PEPFAR a little bit. So for someone who hasn't heard about PEPFAR, at all. How would you describe PEPFAR for them? What is PEPFAR?
Okay. In my professional journey, after the thank you for that question. I left the local government and I joined the game project in Lagos. Let's start from the game project because that was the one the background I gave you was a pre-PEPFAR project era. Sorry, the pre-PEPFAR era. Now we are looking into the PEPFAR era. We didn't know what PEPFAR was in the early 2000s. So I joined the FHI game project. They stole me away. They stole me away. FHI game project, the global HIV AIDS project in Lagos State. And I joined them as HIV counseling and testing technical officer. But I had a combination of PMTCT, like it was, okay, this is the portfolio now. HIV counseling and testing / PMTCT technical officer. That was my portfolio initially. I joined them. So as time went on, the PMTCT was given to the because then there were limited people who could walk and talk this talk about HIV. So as time went on, doctors were drafted to take up the PMTCT aspect, which was the treatment aspect for women, mother to child transmission of HIV, that aspect. So I was gladly ready to work with them in that area. So I was left with the HIV counseling and testing part of that designation. So we started that in 2005. So 2005 is the kind of, for me, the birth of the real thing, like the real work. As at that time, we had already laid the foundation with the LACA, so the community was already saturated with my leadership then. So when we started, we didn't know what PEPFAR was, right? So we started doing the job with FHI Gain project. The first one was FHI Impact, but now we have FHI Gain with the leadership of Miss Dr. Kano in Lagos. So I've been the HIV counseling and testing officer because of the enormous work in the community. We started working with FHI Gain projects in Abuja. We collaborated with FHI Game Project, which is the headquarters actually in Abuja. Abuja is the capital city of Nigeria, right? So we started working together with Simon Cartier, who is the chief HIV counseling and testing specialist in Abuja, and his team. And then we in Lagos were interfacing with him, and we were doing this work together. And then we started hearing about PEPFAR. PEPFAR was actually established. PEPFAR was, let me say what PEPFAR is, the US President's emergency plan for AIDS relief. It was inaugurated or established, authorized in May of 2003. May of 2003 by the then President W.H. Bush. So President Bush, we want to say thank you. The people of Nigeria are saying thank you to you for that initiative. The PEPFAR of the US President's Emergency Plan for AIDS Relief is an amazing initiative pioneered by you. Thank you so much from the people of Nigeria to you and the people of the United States, the taxpayers' money. We are grateful because PEPFAR saved lives. You saved a lot of lives. You brought people to treatment. You gave them life. And this is amazing, and we are saying thank you. Thank you to all the teams too in Nigeria who fought this fight. So when PEPFAR came in 2004, actually, when PEPFAR was authorized, 15 countries 15 countries were supposed to benefit from this initiative. And Nigeria was one of them, one of the countries that was benefiting and benefiting from PEPFAR funds. So we had countries like South Africa, Kenya, Uganda, and then Nigeria, just to mention a few because of time. Nigeria was a beneficiary from those initial 15 countries. Why? Because those 15 countries were high burdened HIV countries, and they were also resource constrained, So PEPFAR funds went a long way, did a great job, and saved lives. Nigeria then was, Nigerian HIV prevalence was 5.8%. And when I say prevalence, I mean number of new cases and old cases. So it was 5.8% of the then population. And then that being the background, in FHI, both in Lagos, both in Lagos and Abuja, but for me in Lagos, we started with strategies. What strategies are we going to now use to reach out and get those who do not know their status? And we started with generalized testing. We had normally with the HIV pandemic, countries were given targets from the OGAG, that is the Office of the Global AIDS Coordinator. We get targets to be reached in each country or each partner and all that. So we had our targets and we had to meet those targets. How were we going to meet those targets? Doing it alone wasn't sufficient. Having the first VCT, Voluntary Counseling and Testing Center in Lagos, wasn't going to do the job. Having the lacquer on the ground itself and community people wasn't going to do the job. We needed to saturate the whole of Lagos State. So Lagos State had a population of 44 million then. 44 million people. And how was I going to do that? So I, met with my team and my state manager, Ms. Kanu, and we talked about hiring and establishing a mobile team. And for each state supported by FHI, this worked miracles. It worked miracles. It was just like, okay, let's do this, let's do that. And it happened that we inaugurated the first mobile counseling and testing team in FHI game project. It was in Kano, it was in Abuja, it was in Calabar, and it was in Anambra State, as well as Lagos State. So we had 5 states that had well-equipped suburban vehicles that were going to had to reach terrains and had to reach areas, working their hearts out to wherever they went to. They were going to establish a center there. Then it was called VCT Center, a center there, and they would do their mobilization and they would test the people. So our funding, I told you funding, you don't see them, you don't touch them, you don't see the dollars, but you see the commodities, you see the supplies, like rapid test kits. They bring all we have rapid test kits in our storage, and then they take them to the community and the work. We had all the supplies, like the stationaries and everything, they needed to do this, to achieve this goal. And this was done in 2005 when I joined, and I hired 7-member team mobilized for the mobilization of the mobilization team. Each state had 7. So these individuals were amazing individuals. They went in the community and they actually tried all they could to meet all the targets. They worked with the LACA, they worked with the community stress, some strategies they used in the community. So this was the beginning of PEPFAR. PEPFAR funds were used for those outreaches, community outreach, community-based testing, targeted testing. We started now with targeted testing. So that was done for a 3-year project in Lagos State. So when I joined, now I'm moving, I joined the CDC, the Centers for Disease Control and Prevention, as the senior program specialist for HIV counseling and testing. I took up I was the first individual to man that portfolio, and PEPFAR had already begun, and we were able to, through the CDC mechanism, we had implementing partners, and that mechanism is the cooperative agreement with the Centers for Disease Control and Prevention in Abuja. So during my time there, these projects that are funded by PEPFAR, they are 5-year projects. They are always 5-year projects. And these mechanisms, through the PEPFAR CDC pipeline, is done by the partners applying, like it's a solicitation. They apply for the grant, for the award, because CDC don't do grants, USAID do grants. So CDC gives them the award for five years. So for the 5-year projects, we had partners applying for the HIV counseling and testing, to do the HIV counseling and testing in the community, whatever state they are. So once they are approved, once they get the approval, the cycle begins. The first cycle begins for the first 5 years of that project. So I was privileged to have close to 20 partners that I managed for the first 5 years in CDC country office, CDC Nigeria country office, the US Centers for Disease Control, because remember that we have the Nigerian CDC as well. So this was the US CDC. So I started with those partners. Some were local partners, some were international partners. But the mechanisms from the CDC headquarters in Atlanta. And I also worked with the interagency working groups. Interagency, and when I say interagency, I mean the USAID, the DoD Walter Reed, and the CDC, the US CDC projects of PEPFAR. So we, the interagency, manage the PEPFAR funds. We all manage PEPFAR funds. They had IPs. We had, they had implementing partners. We also had, CDC also had implementing partners, not just in HIV counseling and testing, but also in other areas like OVC, that is orphans and vulnerable children, strategic information, HIV counseling and testing, PMTCT, ART program, TB, PEPFAR was all over the place. PEPFAR is amazing. This is the largest commitment of any nation to combat HIV scourge in the history of the world. That is PEPFAR for you. A single nation to combat a single disease that has ravaged, a pandemic that has ravaged the world, and was able to intervene, was able to provide funds to countries. Now we started with 15. Before we started with PEPFAR started with 15 countries. Now they are in 50 countries all over the world. That should be an applause, a big applause for them. And I really thank all the presidents that have supported PEPFAR all these years. I thank the OGAG, and I thank all the families, all my colleagues that we all worked on the field tirelessly in those days. So we started with that program, and the gender too was added to my portfolio. So in working in CDC, there was a lot involved. We worked with the Federal Ministry of Health, the HIV/AIDS team of the Federal Ministry of Health. CDC, the interagency working group, we all worked together, with them. And we did a lot we established, what we did? We developed curriculum for HIV training. We developed a national curriculum for HIV training. HIV counseling and testing, training. We developed manuals for conducting HIV counseling and testing. We developed strategies. We started with train capacity building. In Lagos State, while I was there with, so I missed that. While I was there with the game project in Lagos State in 2025 to 2027, I and my team from Abuja, we trained individual nurses. Lagos State has 20 local governments and had 20 local governments and 20 general hospitals. So in those general hospitals, what we did was to train 2 individuals each from each local government. So that's 40, right? Build their capacity to be able to man the VCT center. Then it was VCT center. In each hospital, we decided to have like a space for voluntary counseling and testing. It was called voluntary counseling and testing, but when we got to Abuja, we decided to, then we were still working. FHI Gain in Abuja were working with the Federal Ministry of Health. I wasn't working directly with the Federal Ministry of Health because I was in Lagos. So FHI Gain was working with the working committee. They would send those messages down to me that now this is what we are going to do. We are going to develop strategies. We are going to do this. This is what we've done. And then we'll take it to the hospitals. So this VCT center, for example, let's take Ikeja local government. In Ikeja local government, you have the general hospital. And in the general hospital, you have a space where the government has given us. So one of the contributions of the government, of the Ministry of Health in Lagos State, was to work with us to make sure that the health care providers, their capacity was built to be able to man those centers. So we got 2 nurses to be trained. Their capacity was built to be able to provide confidential counseling and testing with accurate specificity of rapid test kits. Then it was rapid test kits. And then be able to disclose. It was confidential HIV counseling and testing. It wasn't marriage counseling. Marriage counseling is totally different. But HIV counseling and testing is very sensitive. It could break a marriage. It could break partners. It could mar a lot of things. So we trained them to make sure they were able to specifically counsel people. You don't advise them. You counsel them for them to make an informed decision to take the test. So now we have all these booths, in these 20 local governments. We trained, I can beat my chest to it there. These trained nurses had what it took. And then we started with the provider-initiated HIV counseling and testing. That was a strategy. So provider-initiated testing and counseling means when anybody walks through the door of the hospital, they will pass through the voluntary counseling and testing site to see the provider. Before a doctor will see you and to get your complaints and then treat you, you first have to go through the voluntary counseling and testing. You have to go for voluntary. They need to know your status. Why? Because with HIV, you could have some other opportunistic infections like TB, and the likes. So if they know they know their status and the provider know their status, the provider will be able to link them up to ART. That's where the ART treatment starts. And HIV counseling and testing is the entry point. So with PEPFAR, we were able to do all this. We were able to build capacity. We were able to establish VCT centers that has become, and then we did standalone centers too. In the community, there were standalone centers. These are not initiated by healthcare providers. These are initiated by the community people. So that is a standalone center where people just walk in, and after, they do a little bit of community mobilization and they refer them to the center. So people go there and they are tested. And then we increased our testing strategy. Our targets increased. As we worked, our targets increased. We were able to meet our targets because we put all that it took to, we were in the community, we are also in the hospitals. So everybody who was sick will definitely go through HIV counseling and testing, know their status, to be able to be directed to put on treatment. So that was what happened in that Lagos state. But now we are in Abuja in the PEPFAR era. So with PEPFAR funds, we were able to get, for my portfolio, which is the HIV counseling and testing portfolio, I was able to manage, provide leadership, and collaborate with 20 IPs, that is CDC implementing partners, through the cooperative agreement. I was able to manage their budgets. I was able to review their reports, their narrative reports, their programmatic reports. I was able to review their financial reports. I was able to interface these reports with CDC Atlanta, which is our headquarters. I was able to review, I was able to ensure that PEPFAR funds were being used judiciously for what they are meant to be used. These IPs at their beginning, they do their budgets, okay? The budget is like the Bible, and the cooperative agreement is also like the Bible, their Bible. So we read these cooperative agreements, we live it, we use it to do our jobs. So I, as the leader, the lead activity manager for a project, or a lead activity manager for an IP, in that implementing partner, they have a team. They have a team. They have the principal investigator, you have the business official, and then you have the team of 7. They're all like 7 or 8. They're not more than that. So I visit them. I do a lot of site visitation. I visit them. They project whatever they are doing to me. I ensure, look at it line by line, like, okay, and ask questions and see if they are derailing or not. So I provide them guidance and bring them back, And we're able to do this for 5 years and more, until projects were over, and then we started again another cycle. So for the HIV counseling and testing IPs, funded by PEPFAR, they bring their budget. We see that from the beginning of the project, you look at the, project cycle. I kind of manage the projects, all the projects, and it wasn't easy, but I was able to do that and report back to, because we do what we call country operational plans every year. We report to DC, and also we report to Atlanta, CDC Atlanta, but the interagency team, we all report to Washington for another funding cycle by OGAG. OGAG will review all we have done. And when we do our site visits, we ensure that the SOPs that have been laid down, partners are abiding by those SOPs. Standard operating procedures are guidelines. They cannot afford not to, follow them. And also, we do regular site visitation. I'm always on the road. I'm always in difficult terrains. I'm always in the riverine area, hard to reach area. And all this we were doing with strategies. What are those strategies? I talked about provider-initiated counseling. I'm also going to talk about couples counseling. For us to reach so much people, we had to look at the community. Couples counseling was kind of integrated with gender-based violence. But let's talk about, let me talk to you about couples counseling. So we came with the strategy. We worked with it, not just us, but CDC Atlanta, also HIV counseling and testing team. We all worked together, and we came up with the provider-initiated counseling and testing. We came up with couples counseling, where you have couples come as couples, and then you provide the service. This is particularly difficult because if you don't do it well, if you are not well trained to handle the couple, the marriage is over right in front of you. The marriage is over. So we don't want to break people's marriages. We don't want to break people's heart. HIV is hard already. It's hard already. And now PEPFAR has come to provide free. I remember we did an advocacy to the government of Nigeria to make ARTs and HIV counseling free. And as God will have it, they bought it, they ran with it, they bought it, and they said, oh yes, let's do it. People should not be paying for counseling and testing. People should not be paying for, treatment. This should be free. They're already burdened with the virus. And the government did great to have done that. Everything became free, even before PEPFAR arrived. People were testing free and people were assessing treatment free. That was how we were able to get so many people to get tested. And I will say that as at 2010, we had already tested over 100,000 Nigerians, over 100,000 Nigerians. And I think today, millions have been reached with the testing and counseling. And we are just doing some mop-up in this 2020s. We are looking at the UNIAIDS strategy of the 95 targets for 2030. So what UNAIDS is saying is that we have to reach 95% of people living with HIV/AIDS who don't even know their status. We have to reach 95% of that target group. And then we also have to reach those target groups that already have known their status. We also have to reach them and put them on treatment. 95% of that group should be put on treatment. And then the 95% that has been put on treatment should experience viral suppression. That 95% too should evidently experience viral suppression by 2030. So that is exactly, I think, where the government is right now, where everybody is in Nigeria right now, because the data is everywhere. So, yeah. So we did a lot of work in Nigeria. We did a lot of all those strategies that I told you about. We developed curriculum. We developed manuals. We conducted a lot of training. Oh my goodness. We are always building capacity. We're always organizing workshops. We're always making sure that we're on top of our games and that people were doing what they should be doing. Sometimes I am in the counseling room, just listening to my counselor and ensuring she's doing the right thing. And then we also introduced the intimate partner testing. Like, intimate partners are partners who are having sexual intercourse. Probably some of them are just careless, without condoms and all that. You have to also teach them how to use the condom. And when they are positive, that is the crux of the matter. When they are positive, you know how to disclose the HIV testing result. Initially, HIV didn't have a face. We needed to put a face on HIV. And in mainland local government, I remember, before I left, I was able to get Dr. Mate Milola, thank you. He was the first face of HIV in Nigeria. God bless you. Dr. Mate Milola, I was able to get Dr. Mate Milola to mainland local government, to the LACA, to give us his testimony on how he was affected, how he was affected by the virus. And that was in the early 90s, and the 2000s. And when they saw Mate Milola, it dawned on them that this was really real. AIDS know the show for face, now move to know your HIV status. So we started Dr. Mate Milola and Mohammed Anwalu and his wife Lucy. Thank you so much, Lucy and Mohammed. They were the ones that had they put a face to HIV. They were infected. They were people living with HIV and AIDS. And Dr. Mate Milola and Anwalu were the ones that also empowered us to be able to do the work as well. So with treatment, PEPFAR funding, they too were always on the table because we couldn't do anything. In the LACA, when we established the LACA, there were no people living with HIV/AIDS. Nobody wanted to identify that they had HIV. So the LACA had all the groups, all community people sitting down and with their beautiful faces, and we were talking, we had meetings and meetings, but there was no representation of HIV, person living with HIV. That was the only thing I think we missed because we couldn't get anybody to come and say, oh, I have HIV. So when Matamilola came, I invited him and he came to local government, to mainland local government. He was amazed to see the work I was doing with all my team and everybody. And he was like, he was going to tell his testimony about how he got infected and how he came out and everything. And that kind of like gave them, put a face on the virus. And that was really good. So when we had all our meetings and with our partners in CDC, we ensured that the HIV community, people living with HIV, were on board. They were always on board. Even in the NACA meetings, when we attend NACA meetings at the national level, people living with HIVs were represented because it's about them, not us. So the support was for the people living with HIV and AIDS, for care and support. They had support groups, and they had partners that were working with them. So I wasn't actually implementing. CDC really wasn't implementing, but we're implementing the PEPFAR. We're implementing engaging partners, not just CDC Nigeria alone, but all PEPFAR countries. It was the same mechanism. They had partners that will be funded for the 5-year project to conduct HIV counseling and testing in the country, in the states where they are, in the places where they are, and they will report back to us. And we will review their financial records, we review their carryovers, we just support them as much as possible to make sure they succeed and they give us those targets. So I was always on the field, supervising, providing leadership, providing coordination, ensuring that PEPFAR funds were just being expended the way they should be, because we didn't want OGAG many times OGAG came visiting. OGAG team came visiting. That is the Office of the Global HIV/AIDS Coordinator. They came to Nigeria visiting. They saw, and they believed what we were doing. The reports were showing, and what they saw on the field also matched the reports we sent to them. And that was a great job. That was a great work we did when we were there. I also want to talk a little bit about the gender aspect of PEPFAR. I was the HIV counseling and testing program officer, but because there was nobody to man the gender aspect of PEPFAR, I was drafted to do that. So the gender portfolio, we were doing this, we were working, the PEPFAR gender portfolio established the working group, the interagency technical working group, which comprised CDC, USAID, and DOD Water Rights. They also had representatives. I was the representative for CDC Nigeria, US CDC Nigeria. So we were always meeting with the US gender team in our different offices here in the US. Though we're in Nigeria, we always do a lot of Zoom meetings and all that. So we were able to establish the gender desk. Why was it necessary to do that? I think as at that time, Nigeria had a technical group on gender from the federal level. This gender technical group conducted a study about gender interactions in the community, and they came up with very, very their reports on gender-based violence, especially in relation to HIV. So that prompted the Nigerian government to establish technical groups to handle gender-based violence. It was the survey and the research showed a lot. Permit me. This is one of the gender-based violence book. I'll call it a book, but I think it was like it's like an intervention and strategies for gender-based violence in Nigeria. This was done in 2008, and all the working group committees that did this job, they are ingrained. Their names are ingrained in history. The gender-based violence in Nigeria, the study brought out a lot of violence to adolescent girls, women, young women, boys and girls. But the women were disproportionately affected. And gender-based violence had a connotation, had a relationship with HIV transmission. Why? Because the women couldn't, like, if you don't mind, I'll just drop this. So the women are disproportionately affected because of inequality in terms of gender activities. In Nigeria, the patriarchal system is still in use. The cultural masculinity of men gives them the powers to control the women or the girls. Some of these girls were raped. Some of them could not. There was early marriages, like they don't have a say. They are young girls, adolescents, and we didn't want them to come down with HIV. Many of them came down with HIV, but we didn't want them to get infected. So we had to mitigate that. That was why we came in to work with international development partners like UNFPA, UNFPA. I worked with them. UNFPA, women, the Federal Ministry of Women Affairs, UNICEF, WHO, a lot of UN partners. I was working with them from CDC as a CDC representative on the gender desk. So the technical working group too, we're all there. You are the interagency technical working group. So what we're trying to do is, because there's so much relationship between gender-based violence and HIV. Gender-based violence is a violation of human rights for the women. It violates the women's right because they cannot negotiate safer sex. They have no economic empowerment. They have no say. It's either the man's way or the highway. The inequality is so much that the women are just left to some of them come down with broken bones after the gender-based violence is done. Some of them come down sick. Some of them get pregnant because they are forced to have sexual intercourse without protection. Some of them are infected with HIV. The one that is most difficult is when they are pregnant and they are infected with HIV. So what we do, we don't do it as international agencies, interagency technical team, but we support the partners who are on the ground, because partners are funded to also intervene, provide some interventions for these women. So because of the link of gender-based violence to HIV, these partners would ensure the inequalities aspect, ensure that the women are supported economically. They are supported economically. They are introduced to micro financing. They get loans to conduct their trade, to go to farm, to do sewing, so they kind of build their capacity, and they kind of like train them to be more, just empower the women, to be able to, to be more economically viable and dependent, and also train them you educate them for them to, education, you train a woman, you train a nation, to educate these women to have that self-esteem that, I can do this, I can do that, and because of the system that we own, the men and the boys, the young boys and the men, They are not affected in it. Some do, but it's very, very rare. So what we do is to divert their attention, So we divert their attention to social activities. We engage them to, social activities, like engage them with football, snooker games, or all these poker games. Engage them, train them, educate them. That's all the partners do to ensure that GBV is reduced in the community, because GBV, gender-based violence, is a fundamental violation of any woman, of any human woman rights, and we were able to work with all these partners. And I want to thank the development partners, all the development partners that I worked with. This is me, Anthonia. I worked with in Nigeria. Thank you for all the work you guys have done. We have done. It's amazing that we were able to, come this far. I also want to thank the Ministry of Health, Federal Ministry of Health, Lagos State Ministry of Health. Thank you, everybody, because we're able to do the job. Without you, we couldn't have been able to do it. And just one more thing to climax this is that the Nigerian National HIV/AIDS Indicator and the impact survey has all the details about the current national prevalence, the accurate current national prevalence of HIV/AIDS in Nigeria. That document is the document that spells out how far we have come with testing, which is the entry point. They are putting people putting people with HIV/AIDS on treatment, and then also they are like transitioning to targeted testing at high yield areas. Not just generalized testing has been obsolete right now. We don't just want to waste the test kits and waste our time and waste energy, just generalizing and testing everybody, but to target high yield, high risk areas and provide testing and counseling to them and put them on treatment to achieve the UNA 95% HIV/AIDS achievement, to put them on treatment and also suppress their viral load by 2020. So we are working together with UNAIDS. We are working together with all partners. We are working together to make sure that everyone is healthy, free of HIV/AIDS, free of HIV is the infection, AIDS is the disease. So we don't want to see that. We want to mop up. So we are doing mop up right now in Nigeria to ensure that everyone know their status and they can prevent the virus. I hope I've not left anything.
Thank you so much. Thank you so much. Thank
You're
you.
welcome.
Yeah, just those are like really detailed explanation of all the work, and thank you. Just some questions were coming to mind as we were speaking.
Okay.
You talked a lot about partners.
Yeah.
So I was wondering, like, how were those partners chosen? How did you decide which partner you were going to bring into the project to work with the PEPFAR fund? Thank
you for that question. Like I told you, with CDC, we have mechanisms. Partners all over the country. People or projects all over the country, when the solicitation for projects come up in the PEPFAR, I think PEPFAR site or so, the partners apply. Everybody applies, right? And then at the time when it's closed, we have applications as huge as this. So what CDC does is to deploy us to other countries to review those. We don't actually decide for Nigeria. I was in Ethiopia, Addis Ababa, to participate in solicitation review of applications for other countries. So you want to look at the application from the beginning to the end of the application. You want to know if that partner let's use ABC partner, for example. This ABC partner is applying for these projects, right? This ABC partner is saying, oh, we will provide HIV counseling and testing. So we know that this one is for HIV counseling and testing. This partner, another partner is saying, we will provide ARTs, that is antiretroviral therapy. You separate that. That partner is going to provide ARTs. So this one is going to provide strategic information. This one is going to provide PMTCT. This one is going to provide. So as you are looking at those applications, you are reviewing it from the beginning to the end to make sure that it meets the criteria. There are a lot of criteria before you can say, oh, this partner is chosen to provide this service in that country. Because I was posted to Ethiopia, Addis Ababa, to review what I'm telling you right now. So I reviewed with our team, and the other countries will come to Nigeria to review, right? So they review all that, they select them, and they put them in the different portfolios. So for the partners, for the people that came from other countries to review Nigeria's applications, they also will file them according to the portfolio. Maybe it's PMTCT they want to provide services for. You look at their budget, you look at their narrative, you look at strategies they're going to use. You look at, is this partner making sense? Is this PEPFAR funds? Does this partner look like a partner that is serious, that has met the criteria for choosing this partner to provide this service? That's what you're going to be looking at. And because you've been trained to do it. So when we do it, we select all the partners we think. Some partners, when you look at their application, it makes no sense. You just put it aside. And then you go on to the next partner. And you make double sure that this partner that you are choosing to provide HIV counseling and testing services in Ethiopia, for example, is eligible, will be able to use judiciously PEPFAR funds. So you give that partner, you select that partner. So that's how we're able to select them. And when we do that, we leave the country back to our country. So months after, they give us the partners that have been chosen that met the criteria, that are able to deliver, that we are truthful, that have personnel, that have the technical know-how, that have everything it takes to provide PEPFAR services. So that's how they were chosen. And when they come on board, they submit their budgets. Everybody submits their budget for the first year. And then we take it up from there. We get to know each other. We get to talk to them. And then PEPFAR headquarters to also come. These are all mechanisms that are done within the project. So for PEPFAR, we were working with PEPFAR. PEPFAR was working with us. We were working with headquarters. Headquarters was working with us. We were working with OGAG. OGAG was working with us. And that was how we were able to get those partners on board. And let me tell you one thing. For all the partners, I want to say thank you. You guys did a great job in Nigeria. And you were honest. You were truthful with PEPFAR funds. And you disbursed PEPFAR funds the way they should, in terms of commodities, supplies, and throughout my visitation, I had no reason to not applaud your job. I did a lot of reviews, like you reviewed their budgets, their programmatic quarterly, monthly, annual reports. You really scrutinize them. This is not a job that you just sit down and you really, really, like, you have eagle eye to make sure that a dollar was spent for what it was meant for. Because some of these IPs, they may be smart, but these ones were not. They didn't prove that they were smart. They did a great job. And I'm very proud of them because they didn't give me no issues. Because I will take that budget and I will sit with the budget and I will look at that budget and I will see and I will make sure that every T was crossed and every I was dotted. I made sure, because it was going to come back to my table, right? If I don't do that. So some of them, and there's one thing about the PEPFAR funds. When they give you $10, they give you like $10, let's say $10. Those $10, you have to expend that $10 on that project. You don't have carryovers. And if you do have carryovers, we'll talk about it. This is your first carryover, right? Don't let it happen again, because it looks like you're not using this money. And if you're not using this money, you're not going to be funded the next cycle, because you're not working, right? I don't see the results. We have to see results. How many people, because we have indicators, HIV counseling and testing indicators. How many people did you reach? How did you reach them? When did you reach them? What are the strategies you used? And what are the number of people reached at so time, so day, because they have counselors everywhere, right? So those counselors collate all that data, they send to their office, the office collate the data and send to me. I collate all the data of all the 20 partners, and I collate those data and I report to headquarters. That's how it works.
Can I ask a question about the beginning of the cycle when you're choosing partners, right?
Right.
One of the things about PEPFAR was that some of the money was going through faith-based organizations.
Yes.
Right. So can you talk a little bit about what you saw with?
Sure. Thank you for that question. I actually mentioned that even at the inauguration of the LACA, we had faith-based representatives there, faith-based organization representatives. And then at the national level, at the PEPFAR CDC level, we had partners that were funded to provide HIV counseling and testing too. The mechanism is basically the same, whether you are a faith-based organization or you are a Catholic. We had a lot of Catholic projects. We had a lot of Catholic CCCRN, Catholic something, we had that too. They did great. During my project visits, I visited the mission, the Catholic mission. I visited the to see what they were doing and to see if they had supplies and to know if they had challenges and to know if there was anything that was debarring them from meeting their targets, because they had targets too. They are like any other partner. They were all our partners, and we ensured that we supported them as much as we can. And that was why I was always on the road. I was always in the field. I was always in the centers. I was going from center to center. There was no state I did not visit. We were always on the road to make sure that we give them all the support. So it wasn't actually like, because they are faith-based, they are specialist or whatever. No, because even in the church, they had issues, they had problems, they had people coming down with the virus. They had to also use the platform to preach the gospel and also talk about people, doing the right things when it comes to HIV. Because let me tell you, we're all social animals. We are social. We are human beings. People have to have intercourse. And because this virus is so bad, it carries 80% of that. Mother to child transmission is something that is another ballgame altogether. So this woman is pregnant. She's already burdened with her pregnancy. And then you break the news to her that she's infected. And the baby may be infected through delivery or through breastfeeding. So it's something that we had to. And I want to thank PEPFAR. You know why? Because with PEPFAR has been able to expend about $8 billion from the time of inception to now. $8 billion for the fight against HIV and AIDS in Nigeria. It's all on record, right? They were able also to save lives. 26 million lives. 26 million lives were saved. And more. But the data we have right now says 26 million lives were saved. 7.5 million babies were born HIV free from mother to child, PMTST, because of PEPFAR and PEPFAR funding. PEPFAR has done a great job, you understand? And also, they are also reaching people with HIV counseling and testing. They are also reaching people that are living with the virus. They have other opportunistic infections that are being treated, TB, The PEPFAR also is supporting TB funds. Some other people might have a different opinion, but the data that we have right now, you go to the PEPFAR website of the Nigerian community. These are all written all there. It's all a fact, because I started this work as early as the early 90s. So I know what I'm talking about. I've been in this system, in the Nigerian system, until 2016 when I left and I migrated to the US, And here in the US, whatever qualifications you have in any country, you can work here with it. So I had to go back to school to get my licensed as a registered nurse again, to work here in the US. So it is amazing. Thank you for that question.
Thank you so much. Can you tell us a little bit more about your strategy for the prevention of mother-to-child transmission?
I didn't work so much with mother-to-child transmission like I did with HIV counseling and testing, but I actually collaborated with the doctors who worked on prevention of mother-to-child transmission. So, of course, the entry point is HIV counseling and testing, confidential counseling and testing. So when the woman comes down with the virus, we refer them we work together. It's like a jigsaw puzzle. We all work together as a team. The PMTCT, the HIV counseling and testing, which is the entry point, we test them and we send them. We ensure when we refer them, that referral is completed, because we don't want to lose nobody along that line and spectrum. Once you get tested, we ensure that you get to the PMTCT to start your evaluation and treatment. And when the baby is born, the PMTCT colleagues, doctors, they know what to do to ensure that the baby is on zidovudine or whatever ARTs the baby is on. The mother is also on zidovudine or whatever the mother is on. The ARTs are, they have access to ART, and the mother and the child are on treatment. And then the baby, in the next probably 1 or 2 years, will have viral suppression and probably zero. Babies don't even come down with the virus, because now that the mother is infected and is on treatment, the viral load is suppressed. So delivery is going to be well taken care of, to make sure that the baby, the baby's blood and the mother's blood don't mix, and then baby is born free of HIV. So most babies are born HIV free. Yeah.
Thank you. You also talked about a country's standard of operation, and I was wondering, how do you ensure that, you said they cannot deviate from it? Like, it's just like the COP, that's what you call them.
SOP.
SOP. The country's SOP. You said they can't deviate from it. So when PEPFAR say this is the SOP, this is how you should do this, they cannot deviate. So how do you ensure that local knowledge are also brought into those strategies and those procedures?
Local knowledge. We work with the implementing partners. They are first, how will I put it? They are the ones we work with. They're the first in the line that we meet, we talk to, we interact with, because they have a duty to report to us. We have a duty to ensure that they don't deviate, they don't derail. So the standard operating procedures were developed by CDC. They were developed by CDC. We developed that standard operating procedure as a guide to make sure that every partner is doing what they should be doing. And so with the SOP in one hand, you are visiting the site. They know what to do. So we don't build, PEPFAR don't build. We don't build like visiting centers or build a house. No. The government does their part. The government will give us a space, and then we will renovate the space with PEPFAR funding. So we come with the funding, we renovate the space, we put audiovisuals in the room, They want to build a workshop room. They want to do a work. They don't have a workshop center in the hospital, for example, in rural areas, hard to reach areas. So we make use of what is on ground, and then we solicit government help because the partner says, "Oh, we've been to government to give us a space. Government has given us at last." There's a procedure, and the bureaucracy in government is something else that we should be talking about, right? So partners, they suffer bureaucracy a lot. When they apply for something, it takes forever to get the response, either from the Federal Ministry of Health, Federal Ministry of Women Affairs. It takes, the bureaucracy is tight. So, but they get it, right? They get it at last. So they give them that space, and then we come in. PEPFAR comes in. They put a table there. They put chairs in the room. They put the audiovisuals. They give them everything they need to train, to build capacity of all their trainees, all their peers, to create more peer-to-peer educators that will go into the community. So when PEPFAR is leaving, PEPFAR is also there. PEPFAR has enabled a lot of people, a lot of countries. PEPFAR has done a lot. Without PEPFAR, there will be a lot of low expectancy, low life expectancy. People will die. If PEPFAR leaves, people will die. Government will be there will be weak health system. There will be a lot of weak systems because these systems were strengthened by PEPFAR. But we expect that the government will pick up from where PEPFAR has left. We just pray they'll be able to do it. Because let me tell you, when I was working, sorry to take you back, when I was working as the principal AIDS action manager for local government, for mainland local government, we had no budget. We had no budget for HIV/AIDS. We had no budget. If you don't have budget, how are you going to get the LACA together? It was when Olikoye Ransom Kuti and others, when they sent that circular to us to establish the LACA, they specifically in red mandated the government to ensure that there's a budget for HIV. That was how we started with a budget for HIV. I think they gave us like 300,000 naira. 300,000 naira for the first spans of work that we did. To get people together, you need funds. So if PEPFAR is leaving, we expect the government to also take up from where PEPFAR has left. So these, all the structures that PEPFAR established in Nigeria, they're all over the country. They're all over the states, in the hospitals, in general hospitals, where you see all these beautiful visiting centers. Beautiful. You see the centers, they are magnificently beautiful. Not that PEPFAR built, but PEPFAR was able to support them to have a standard for HIV counseling and testing, and also built the capacity of the people. So to answer your question, I just pray that the government will step in. Government has always been stepping in. They've tried because they give, and then PEPFAR meets them at halfway. And that's how we've been. It's been a tripartite kind of partnership between CDC, or let me say the interagency working groups, the government and PEPFAR. So it's been like, that's partnership. But we still pray that the government will be able to do more. I left in 2016. I can't tell you what is going on there right now, but for what we did, we were able to be on ground to make sure that PEPFAR funds were expended and nicely, because PEPFAR, if PEPFAR ever leaves, there's going to be a lot of things to think about. Yeah.
Thank you so much for talking about the impact of Nigerian government as well. Because that was going to be my question.
Your next question, okay?
What were they doing? Were they also, making impact while PEPFAR was there?
Yeah.
But I'll just move on to the next question. So would you say overall, what would you say is the impact of PEPFAR overall? And would you say that the funding, that PEPFAR provided for Nigeria, was that a good use of money of PEPFAR funds?
It was an amazing, for me, it's my opinion. Other people might have their opinion. Some people still think that PEPFAR didn't do nothing. Well, I won't say that, because I was there, I executed, and I knew that the funds were used judiciously. I knew it. I reported it, and I left in high ovation. So PEPFAR is a great initiative by the president, and we are grateful, because PEPFAR saved lives. PEPFAR empowered, emboldened women, young girls, adolescent girls in the DREAM initiative, which was used in the gender portfolio for PEPFAR to address gender inequalities amongst genders. They did great. Your question again, if you might remind me, was what was remind me about your question again.
Was it a good use of money, and what was the impact in your opinion?
Oh my goodness, the impact was enormous. I've been talking for an hour or more. The impact was enormous. This, like I said, is the largest, PEPFAR is the largest commitment of any nation, of America as a nation, to combat HIV scourge in history. It is the largest commitment. And with them being in the country, for example, they built my capacity. I was all over the world presenting. I was all over the world. Tell me where I haven't been with HIV. And what we are doing in Nigeria, showcasing what we are doing in Nigeria. And everybody in Kenya was like, because I had an abstract. I have like 5 or 6 abstracts at that time, talking about how we're doing it. Because people were just dying in other countries like Uganda, Kenya, until PEPFAR came. PEPFAR came with all the funds, American taxpayers' money, for this, for addressing this enormous challenge of HIV scourge, pandemic all over the world, especially in sub-Saharan Africa. And I was there presenting. I will be in Spain today. Tomorrow I'm in France. The next year I'm in Barcelona. I'm in Kenya. I'm in Zambia. I'm in the US presenting. You have to show what you are doing every time, so that without PEPFAR, I don't know what we will have done. And like I said, if PEPFAR folds up and leave today, there will be increase in the spread of infection. People might just forget and go to sleep and then wake up with the infection, because the momentum that was high before is now coming down, is low. And the government should be able to step in. That was why I said, where PEPFAR leaves off, the government should step in. There will be weak public health systems, very weak public health systems. Because if the government is not matching up to PEPFAR funding, how will the system meet the demand for the HIV scourge? How? Because now it's like they're mopping up. And that reminds me, because the prevalence right now as you speak, from 5.8 is now 1.4%, according to data from the survey I talked about. It's 1.4%, and they are still working. People are still in the field working. And there'll also be poor, there will be deaths. Definitely the deaths will increase from HIV and AIDS. The deaths will increase. Nobody can afford ARVs. ARVs are very expensive, but they are free, provided by PEPFAR. There will be stigma again. There will be infant mortality and maternal mortality. It will rise. Infant and maternal mortality will rise. A lot of infants will die, and their mothers too, because of the impact of the virus, and also being PEPFAR folding up and leaving. Increase in maternal and there'll also be shorter life expectancy. I've said that before. Life expectancy will be shortened. People will just be falling down and be dying, because there's no care, there's no support. Like I told you, people living with HIV/AIDS now, they have support groups. And PEPFAR also funds those support groups through partners. These support groups, they teach each other how to survive, survival modes and all that, what you can do about opportunistic infections, what you can do with preventing mother to child transmission, what you can, the groups come together and they share. Not just that alone, they talk about the ARVs and the side effects. How you are on XYZ medication. How is it affecting you? What are the signs and symptoms, and how are you able to combat it? How are you able to deal with it? How are you able to deal with the challenges of you being positive and your partner is not positive? How are you dealing with the fact that your partner is positive and you are negative? How are you dealing with the fact that you have sexual intercourse and you don't get infected all these years? And they talk about this stuff, and it strengthens them. It makes them to look at life as worth living. So they come together and do all this stuff. There's also because of the impact of HIV, the workforce, there will be gradual loss of productivity. People will be sick, they won't be able to come to work, and then there's low productivity, and so many, many, many more if PEPFAR leaves the scene and the government is not stepping in. So I want to urge and encourage government to please, step in. If PEPFAR ever leaves the scene, please step in and see what you can do for your people. Thank you.
Thank you. Thank you so much. Are there some important people that you work with that you would also like us to speak with?
I don't know, because they're all in Nigeria. Some of them have retired, like I have. Some of them have moved. You could speak to Jerry Guamna. He's in Nigeria. I don't know if those in Nigeria or here in America. Both sides? Okay. I would like you to speak to Jerry Guamna. He's the branch manager, branch chief for, I think he's the branch chief of prevention. I don't know his portfolio right now, but he was the branch chief for that in the prevention team, because we had the prevention team which comprised, I was the only nurse on board. They were all doctors, okay? PMTCT, OVC, Orphans and Vulnerable Children, Blood, Meribe was on board, and Jerry Guamnam. So it's a team of 6 in the prevention team, and Jerry Guamna was the chief, the branch chief. So you could speak to Jerry Guamna. You could also speak with Oseni. Oseni is here in America.
You're speaking with him today.
You're speaking with Oseni today. That's great. Igwe is one funny, nice gentleman. I worked on a project of the Pop Council, men having sex with men. We closed down that project after 5 years. It was a U.S. mechanism that was sent to us that we should support through PEPFAR, and they were able to reach, because as at that time the men having sex with men wasn't something. They were people who were going underground. They didn't want to be seen. They didn't want to be heard. But stuff were going underground. Stuff was happening every day between men having sex with men, and we needed an intervention. And Pop Council stepped in with that project. That project reached a reasonable amount of people, men having sex with men in Nigeria. They reached out. They used a lot of strategies, and I give it up to them. They did a great job to reach out to those people, empower them so that they can stop the spread, they can mitigate the spread of HIV. And they gave them a lot of commodities. There were a lot of condoms. There were a lot of other commodities, other supplies to help them stop the spread. But you couldn't change people. So we were able to support them. Though they went underground when the project started, But with PEPFAR, they were able to put a face to it. We had men that were having sex with men, group that was on board, just like the HIV, people living with HIV, the PWHs, the people living with HIV and AIDS. They were on board in all our meetings. This group of people, of men, were also on board. You'll be amazed to know that this group, the people that make up this group, so we really need to support them not to come down with the virus, to do the right thing, to have all they need to meet their peers, because we had to train them. The Pop Council had to train them, peer-to-peer training. They were able to use all the strategies that they developed. This has been like almost over so many years, so I may not remember some of the things, but what I remember is that I visited the project in Lagos. And I was able to appreciate what Pop Council did with the group. I think the leader then was Miss Adela Jauso. I remember she did a great job with her team in Lagos to ensure that men having sex with men, the MSM, let me put it, the MSM group were reached with intervention in Lagos State. And the prevalence, amongst them, with the data that they presented, was significantly reduced. A lot of them were put on ARVs. And this was all PEPFAR, thanks to PEPFAR funding. I just want to say thank you to PEPFAR. PEPFAR built my capacity. PEPFAR made me who I was then, and probably who I am today. I can't tell my story without talking about the opportunity that I had to provide services to humanity and to be on the project and to be able to provide leadership for the CDC projects in Lagos and also in Nigeria. For the CDC, the USAID project impact, FHI impact in Lagos, and also CDC projects in Nigeria for all the IPs. And I also want to thank the IPs because we really worked tirelessly. The APIN, CCRN, Pop Council, like I said, AIDS Relief, CCRN, so many others, so many others. Pro Health, thank you. Pro Health is in Jos. You have also the one in a lot of them. But Andy, thank you for all you do. We appreciate you guys, and we also appreciate the people of the tax-paying community here in America who made all those funds available through the U.S. President emergency plan for AIDS relief, PEPFAR. Thank you so much.
Thank you, ma'am. Just a few more questions and we'll round up. You talked about Jos, and I was thinking about your work in the northern Nigeria.
Oh, yeah.
Was there a reason for that specific focus on the north around HIV issues?
Thank you. At that time, the prevalence in the north too was a bit disturbing. The prevalence of HIV in the north, I can't specifically put a finger to it, but we needed a presence in the north. Jos is in the middle belt, like a plate central. So, but we had interventions in Kano that was manned by my colleague in Kano, Nora. Mr. Nora was in charge of the Kano HIV/AIDS game project, and he could tell his own story because he manned the Kano Kaduna aspect of the projects. Just as I had implementing partners here, he was in charge of ensuring that the Kano state government was, upping their game to ensure that they meet up with the PEPFAR funds as well to continue with the project. So yes, Kano state, yes, and then Jos for Pro Health saturated the whole of Jos. I visited many times. I had my tools. I had my tools that I will use for my visitation, and I'll ensure that, like I said before, that PEPFAR funds are being used judiciously. We're able to support them. They had a lot of facilities that PEPFAR supported, a lot of training gadgets, and to make sure that they deliver the targets to us. Yeah.
Thank you. Thank you so much.
Thank you.
So sometimes the nature of prevention work within PEPFAR could be heated at times. So did you see any of the divisions around the ABC in your work on PEPFAR projects and the prevention of HIV in Nigeria? Were there times that, oh, you can only do abstinence and condom, or were there times that you could do abstinence, condom, and also think about just the use of condom? Were there any restrictions or at some point?
It depends on what you mean by confusion or in the. Did you say confusion? Did you?
No, divisions.
Did you say divisions? There are no divisions. We worked in consonance with the. There were no divisions. We worked as a team. Everywhere you went to, we were speaking the same language. You know, even when I was working with the development partner, coordinating with the development partners, at a time I had to invite them to the embassy. You know, at a time I had to invite all the development partners, all of them were in the embassy. We held a technical, decisive technical meeting where we were able to come up with more strategies. We came up with more interventions. We came up strongly how we are going to interface with the government of Nigeria, especially the Federal Ministry of Women Affairs, to address GBV, to address empowering the women, to address economic empowering of the women, to address child marriage, which was trending then in Nigeria, it was like a cancer, a 13-year-old girl having a baby and having vesicovaginal fistulas. They were coming up with a lot of vesicovaginal fistulas, and nobody was helping these girls. They were too young to have babies. They were even too young to have sexual intercourse. But these babies were having babies, and they were coming down with this terrible problem, you know, leaking urine everywhere, you know. So we took it as a mandate to work. There was no time we had divisions or in terms of prevention. We worked as a team. We spoke with one voice. We met regularly. We held diverse meetings, technical meetings. All my life in the development world, meetings were like, you have to have a meeting by 8 o'clock, you have a meeting by 9 o'clock, you are there with your laptop, you're jumping, you're like a grasshopper, you're everywhere. So it was a delight to work with them, and there was no divisions. There were no areas where we had conflicts or where somebody was saying something and the other one wasn't, because we're always together, attending meetings, taking notes, making sure somebody's leading the team, to working with the Ministry of Health, working with the Federal Ministry of Health, working with the Federal those two ministries, Women's Affairs and Federal Ministry of Health. We had a grip on those two ministries, and we worked together, like coordinate together, just not together, but also with NACA. NACA was the body for HIV. We also held meetings with NACA to also inform them about how far we've gone, what we are doing to empower women and, you know, reduce inequalities, empower the women economically, empower them educationally, make sure the men are, you know, they are engaged doing things that they should be doing instead of beating up the women. And there was this survey that also told us, it revealed so much about some very disturbing outcomes. GBV was like a cancer, and it was spreading fast in Nigeria, and we needed to curb it, and we needed resources to do that. PEPFAR was there. PEPFAR stepped in. They were able to reach all these women in the north, especially, and that was how I told you. That was how when you talk about a baby having a baby, like, what are you thinking? Like, you know, you just can't go into the minds of these people. How a 12-year-old child will be having a baby? How you think a 12-year-old child is matured enough to be a mother? It makes no sense to me. It makes no sense to the group. But we had to help. We had to educate. We had to go there. We had to make sure there was a face to it too. We wanted to make sure that the government heard us. And that was why we are working with the Women Affairs Group. We are working with Ministry of Health, to put legislation to do something, about GBV, about empowering these women. If the women are empowered, they'll have a voice. They will speak up and they will be able to, these gender-based violence will reduce because it was spreading like wildfire. And it was like spectator people were looking in the community, and they don't tell you what causes the fight. The husband and the wife are punching each other and they don't tell you the cause of this fight. When you ask, they don't tell you what causes the fight. Is it money? No. What is it? They won't tell you because people don't talk about sex openly. Husband says, I paid $20,000 on 20,000 naira on her for her dowry. I married her. I sent her to school. Now I am asking, I have to beg you to have intimacy with you. Then he start punching her, break her ribs, break her jaw, break her nose. She is not empowered. She's not empowered. She can't defend herself. She can't do nothing. She goes to the hospital. She can't pay for the bills. The man is not ready to pay the bills, hospital bills. The woman comes down. The woman has no power to negotiate sexual intercourse. She is at the beck and call of this man. Why? Because Nigeria practices patriarchal system where the man with his cultural masculinity and ego and everything, pounces on this woman and turns her to a punching bag and makes her, absolutely unable to fend for her children or her family. So women don't have that capacity to negotiate safer sex. And they end up with HIV counseling and testing. And we don't want those statistics to continue to rise, people living with HIV, because where are the resources to manage these people? So what we do is go in there with our partners and mitigate that and educate the community and teach the men. Some men, it's as bad as some men will say the breast milk is for them, not for the baby. And they want the breast milk, not the baby. And the woman says, the breast milk is for my baby, it's not for you. It's as bad as that, where you see gender-based violence, the women moving out of the house. Sometimes they are homeless on the streets. We have to pick them up, give them a life. So PEPFAR has done great things. You can't tell me PEPFAR has not. PEPFAR has done so much for the women in the north, even in the south, In the south, you have more urban cities, you have more urban areas. Sexual intercourse is going on every minute. Once somebody is being infected every minute because of the exposure. And because of the biological nature of the woman. I've said that before. The biological nature of the woman does not spare us, So we get infected easily than the men. And when we get infected, we can't disclose. We can't tell them, we are infected. Because when we say we are infected, we are promiscuous. That's what you're saying. You are a commercial sex worker or you are a sex worker. And that brings me to the project of the sex workers, because we had another IP, another implementing partner, caring for the red lights girls, for the, So they were working with those girls. They were working because in in HIV counseling and testing world, or in the HIV world, you call it the way it is. If you are talking about the penis, you talk the penis. You don't mix words. You're talking the vaginal swab or whatever you talk about, you call it the way it is. So for the commercial sex workers, they now changed it to female sex workers, because not all of them are commercially inclined. So some of them are just sex workers. They are not commercial. They have 20 or more sexual partners. They just have that urge to have sex and they just do it, not for commercial purposes. So we decided to rename it. Take out the commercial. Let's use that phrase. So we're using that phrase to address the women, because right now we're talking about the men having sex with men. You also have people who use substances. They are all over under the bridge. They do all this risky behavior. They have risky behavior, and this risky behavior makes them vulnerable to HIV. They are engaged in all kinds of risk, like injecting needles, So in the process of injecting, they share needles and they get infected. So we have another implementing partner taking care of those, intervening for them, the IDUs, the sexual workers, and also the men having sex with men. So it was a large portfolio PEPFAR was dealing with, and a large, like I told you, I said PEPFAR is the largest commitment of any nation, of this nation, this blessed nation, to combat HIV. Single-handedly, single disease for so many years. We started with 15 partners, 15 countries, right? Today, PEPFAR is in 50 countries. How is that? How is that? American taxpayers' money. Thank you. 50 countries all over the world fighting this virus, and we are going to win, because I was in Sierra Leone. To provide services and to provide my technical expertise to support the Ebola virus. And I saw, oh my goodness, it's devastating. When you work in communicable diseases and all these diseases, you work in this field, we really need to be careful, right? We got all that capacity building. PEPFAR also did. They too were also supporting us, So we went to Sierra Leone to help the Sierra Leonean team. We are on ground with other partners from Britain, from France, from Nigeria, from US. We are all there. I was in the social mobilization committee, going from community, one chiefdom in Sierra Leone, in where I was posted to another chiefdom, and we had this big tent where you have all the people living with the virus, with the Ebola virus. You know how lethal Ebola virus is? So we saw all these things, and I just pray that PEPFAR, what we have learned from PEPFAR, we've learned so much. We have earned so much. They have built our capacity. Not just me alone, but a lot of people. PEPFAR has reached so many countries, communities, people all over the world. And we want to say thank you. We will try also to match up. I'm sure the government will do that. And if you need my support, okay, I think I'm still available to give you that support.
Thank you. How would you rate the contribution of locally employed staff like you?
Oh my goodness. It's so cool. Thank you for that question. We were so glad to be able to work for CDC. Every one of us, we are locally hired, because for me, before I said Jack, I was already hired, because Lagos State is a chaotic state. Chaotic in a good way, right? Too many people. How were you able to reach this target? Because they saw the targets that we reached. They saw the strategies we used. And I said, it was just not me alone. It was me. It was my team from Abuja, and the Lagos team, and also all the partners, all the IAs, all the implementing agencies. We did it together. And this was what I was able to do. Constantly, consistently, ongoing visitation, because you have to be there. If you don't, they're going to do whatever they like. You will get to the visiting center, you won't see nobody. And patients are coming in droves, So we were able to achieve that, and it was amazing. For the local staff, we are grateful to PEPFAR. We are grateful because not all the local staff are in prevention and care. We have other local staff in State Department. We had other local staff working in visa issuing offices. We had the ambassador. We had the U.S. ambassador to Nigeria office. We had the GSO. We had so many other departments. All were local staff, and we're always happy to come together to share our achievements. We are grateful for the opportunity to serve the country and also serve Nigeria. We were grateful because we had nothing. We were well taken care of in terms of our paychecks were good. As at that time, We were, our capacity, like I say, we that were in the always on the go, always on the move. Our capacity was the most important thing for me is my capacity. I'm telling you, it was amazing. For every country that we went to or we visited, Nigeria was always top because we were top-notch people. We presented our data the way it was, and we are always conscious of what we do because of PEPFAR. PEPFAR have done so much for us that we don't want to like be ungrateful or be ingrate and just because if not, the PEPFAR will have withdrawn its services. But we did that, and we are still doing it right now as I speak. So CDC is still on ground in Nigeria, in the embassy, the US embassy, and they are doing their thing, and I'm sure they are still reporting to Washington and to CDC headquarters in Atlanta. So for the LA staff, the local staff, we are indeed grateful because we are integrated into the family of the US government staff that were there. And because we were locally hired, we knew the terrain, we knew the burden, we're familiar with everything that has to do with HIV counseling, HIV testing, HIV care and support. We knew the people. So we're always in the forefront. We are always in the forefront of the battle for HIV and AIDS, and we are reporting back to our bosses. So we are grateful. We are grateful and we're happy. Yeah.
She said thank you to you too as
Thank
well.
you. Oh, thank
You made
you.
the work possible.
I appreciate that.
Thank you.
I appreciate that.
Right. This will be like my second to the last question.
Okay.
So given that Nigeria is like so multi-ethnic, multicultural, multi-religious, multi-everything, did you have any challenge with the strategies, or was every group, including traditional leaders, religious leaders, was everyone on board with abstinence, the use of condom,
Oh, you
and
talked
be
about
faithful?
Oh my goodness, yes. ABC was the strategy to get to that zero, how will I put it, zero level for HIV reporting or infection. ABC was it. It was part of the song that we were singing then. It was part of the anthem after AIDS No the Show for Face. Then we had Know Your HIV Status. And then we had the use of ABC.
If you know if you use body.
If you know if you hold body, use condom. We had that too. We had a lot of slogans, and we had a lot of shirts, t-shirts with all kinds of slogan, just to be able to drive the message to the people. People, after Matemilola came to that country, to that state, everything changed because there was a face now. People were like touching, are you sure if I touch you, I won't be infected? That was the myth. If you touch somebody, you'll be infected. If you cry, there's HIV in the tears, you'll be infected. If it touches you, you are infected. So there are a lot of myths around HIV then. Well, Matemilola came, everything, they had a face to it, and people interacting with each other. Now we know that if I touch you, I can't get infected. If I do this, I can't get infected. If I have a cut, I have to cover it just in case, But because cuts and all other things carries 10%, mother-to-child transmissions carry 10%, unprotected sexual intercourse carries 80% of the transmission of the virus. So the ABC, with regards to ethnic diversity, Lagos State then, I don't want to talk about Nigeria, but the Lagos State then was basically Yoruba people. The Yoruba group, the Yoruba ethnic group, we all speak Yoruba. I wasn't even speaking Yoruba well then, but with a lot of interaction, because I'm from Delta State. I'm not from Yoruba, but my ex was Yoruba, so I was able to like interact with, started speaking the language, started teaching in the language, started singing in the language, started community mobilization in that language. And we found out that there are some other ethnic groups that were also in the committee, like the Igbos. The Igbos, we had representation on that committee. I told you it was sectoral and multidisciplinary committee. We had other ethnic groups because they also have their communities, the Hausa group, the Igbo group. So they had their chief, their heads represented on the lacquer. So they were able to carry every message back to their communities, their different communities. And the language wasn't a barrier. We all worked together. Like I said, through my life of working in this field, I have never seen the synergy, such cooperation, such oneness to, fight against one disease that is ravaging the whole community. It's amazing. It's amazing. And the love for each other, one another was unprecedented. We loved what we did, we delivered, and we were happy. Yeah.
Thank you so much. So, Jill, before I ask this final
No,
one, do you have
go
any
for it.
questions? Okay. So, is there anything that I haven't asked you that that is important that you'd like to share with us, just as we round up?
Well, there's nothing else that I haven't spoken about. Maybe the Global Health Initiative, because we also we interfaced with the Global Health Initiative. We interfaced with the Clinton Foundation in Lagos, in Abuja. Clinton Foundation was providing services for children. And we also interfaced with the Global Fund colleagues who were working on Global Funds to also reach. We are basically all doing almost the same thing with different organizations and different strategies. So, but it was a great work. It was a great work. I don't know if there's anything I have not touched on. If I haven't, well, we'll talk about it next time. I can't remember anything right now. Well, thank you for having me.
It's been wonderful.
Thank you for having
you.
me. It's
Yeah.
a long story.
No,
It's
it's been
Thanks
wonderful.
so much.
It's been wonderful.
Very grateful.